a lot of times the magnitude of the health effects we're looking at are fairly small. So we have a wildfire smoke or bad pollution, and it might increase your risk of a heart attack by 1%. And that sounds very small. And then people ask, like, well, what does that mean for me? I think, we're so used to working with big data sets, we can forget that those entries in the data sets are people.
Yes.
And anytime there's an opportunity to sort of kind of humanize what we're doing and remember, yes, like, no, these are families. I think that's very valuable.
This is Brewing Better Health, a series from the School of Public Health at the University of Nevada, Reno, where every cup sparks connection and a healthy conversation. Join Dean Muge Akpinar-Elci each month for a cup of Turkish coffee as we pour insights into public health. Today, Dean Muge is joined by Dr. Matt Strickland, Professor and Department Chair of Biostatistics, Epidemiology, and Environmental Health at the School of Public Health.
Hi, Matt.
Hello.
Welcome to our Brewing Better Health video series. And I am so happy to host you in my house and in my kitchen, actually.
Yeah.
And today we will talk about you and what you do and why you do it and how you do it. But before starting, I just want to go to this Turkish coffee piece. We specifically choose the Turkish coffee for this video series because we want to be on the moment and just talk and just connect and just understand people, what they do, and listen. Listening is very important for this series. And also in Turkish coffee, what we call that a cup of coffee, Turkish coffee, is remember for 40 years. Is a meaning is really small act create lasting impact. And I want to start to that question actually. Do you have that kind of moment in your life to make that lasting impact to whole your career or life?
Yeah, it's a good question. I was thinking about this, and there's lots of small conversations that happen. You're like, well, what is the one that I can really think of? But I kept coming back to when I was a graduate student. I was working at CDC in birth defects. And, at that time I was very interested in all the cutting edge statistical approaches and epi methods and doing case control studies and all this kind of stuff. And I think at the time I was maybe not fully appreciating the importance of just like routine surveillance data, core public health data. But we had a surveillance system set up in Atlanta, and once a year we would have a meeting with stakeholders and people from the community. And many of the stakeholders were parents who had children with birth defects. And when they would talk, right, they were, one, so appreciative of the work we were doing, but two, like, what did they care about? They didn't care about the fancy stuff that I was interested in, right? They had a child with a birth defect. They wanted to know what that child's life was going to be like. What was in store for them. And we just needed that core data to be able to answer those kinds of questions. It's not the fanciest thing out there, right? But that core public health data is so important. And that has made a lasting impression on me.
That is very interesting what you tell this story, because people in the many science part right now, there are many issues happening around the science understanding, and people, they are thinking that we are just doing the data for publish more, or just print more fundings. But what you are telling me that literally we are doing for the people to understand and make some decision from this kind of data and how we can move it to that piece. So it's very interesting.
Yeah, I think, we're so used to working with big data sets, we can forget that those entries in the data sets are people.
Yes.
And anytime there's an opportunity to sort of kind of humanize what we're doing and remember, yes, like, no, these are families. I think that's very valuable.
Because it's sometimes, again, I always say that we're not that kind of scientists, just close our door and just go to our lab or just go to our computer just to do it. We are really just in the communities, in a sense, in the public health research and public health understanding. we need to work with them
Mhm.
to, again, also we need to always show what is the researched practice and how we are impacting to later on. So just tell me about how you decided more entering the public health, and just how you are coming to Reno.
Oh yeah, coming to Reno. Yeah, well, that came a little bit later on. Coming to Reno, I've been here about 10 years. I think my interest in public health started as an undergrad, and kind of from sort of a nerdy academic standpoint too, right? Like I was an anthropology major and doing pre-med and things like that. And
That is totally different road you were
it,
taking.
it is, but in my school, my undergrad, we didn't have a school of public health. And so we had people doing global health and infectious disease kinds of work within anthropology. And I eventually took a global health course and was so impressed by the professor's sort of systematic approach to thinking about health across the world, right? And I started to become very interested in, like, how do we know the answers to these questions? These are questions that are so important for humanity. But like, I don't have the tools to know, like, well, what is the cause of this? Or why is this happening? Or what do we need to do to try to fix it? And so I got motivated by that sort of nerdy academic stuff. I wanted to learn how we know the answers to these questions. And in order to do that, you have to take a deep dive into methods and statistics and things like that. So I went into my master's of public health. I worked in epidemiology. I loved it. I felt that I had barely scratched the surface of what there was to learn in that field. So I had no question whatsoever that I was going to get a PhD. I just was very interested in every statistics course I've ever taken. I've been looking forward to. And so then I ended up as a PhD in epidemiology, and I had to decide what I was going to do. And I worked in CDC for a little while in birth defects, but an opportunity came up at my previous institution at Emory University in Atlanta to be a faculty member, and I had a difficult struggle with that, because even though it was very appealing, I really liked what I was doing in birth defects. I thought I was doing something important and also doing something that most other people weren't doing. But I decided to sort of brave it and move into that. And when I moved into academic role, it was hard to do birth defects, because if you're not connected to a registry, you don't have the data. Yeah, so I moved more towards my interest in environmental health and air pollution and climate change and different kinds of things like that. And about 10 years ago, we had an opportunity to come to Reno. My wife, for those who know, Lindsay, is also a faculty member in our school, and we got 2 jobs, and it was closer to family, and Atlanta was just so big with little kids. So we moved here, and it's been wonderful.
That is the part, huh?
Yeah.
But just you explain very nicely, how you grow in the public health field also. But I want to go back to your nerdy parts, because again, we are also trying to, with this video series, we are trying to give the perspective to our viewers to understand public health is very broad.
It is.
There are many different people with the many different backgrounds they are working. You can be the mathematician in many sense, just because, or you can be just a very straightforward statistician, just look at the statistics and, just do everything's your nerdy side. But just give me that perspective a little bit, how you are fitting in the public health field also.
Oh, yeah, sure. So, a lot of my work has been done to inform the standard setting that is part of the Clean Air Act. So the Clean Air Act is a 1970 law that started under EPA. EPA was formed in the early 70s, and it basically provides EPA with the authority to regulate outdoor air pollution levels. And they're not allowed to just regulate for the sake of regulation. It has to be informed by evidence. And the primary evidence is human health. So I've done studies on coal-fired power plant emissions and mobile source like cars and trucks. And we've done wildfire studies. We've done a variety of different air pollution sources, all with the goal of informing that standard setting. And so that's really how my research helps protect public health, right? We do work, we We say, this is the pollutant that we need to be worried about. Don't waste our money on this one. That doesn't seem to be as harmful. Prioritize this. And then if, government and politics works the way we would like it to work, which it sometimes does. It sometimes does, yeah. Then that leads to regulations and changes that improve outdoor air pollution, improve outdoor air quality.
Because with the regulation is, again, I'm trying to give that perspective that what you do is collect the data or take the data and just look at it that way. Our whole goal is how we can help the decision making and how we can bring to for policy perspective to protect the health of everybody. Because sometimes people, they don't see that work because we are really doing very behind the scene. We are not the policymaker, we are not the policy people, but we produce data for them to make the decisions. So your connection with the nerdy part, with that part, is really hopefully help the
and I'm very lucky in my area. Like, there's a very explicit, convoluted but explicit process for how science informs standard setting at EPA. There's a lot of areas in public health where that process is not so clearly laid out. But I've been able to participate in that, not just as a researcher providing my study results, but also as scientific expert who does peer review of the literature and makes recommendations and helps drive the conclusions that are based on the summary of the literature.
But how do you see currently what's happening right now? How we lost the trust of the science right now? Why is happening?
Oh, that's a complicated question.
I know. We are not talking about solve the problem or anything, but I'm trying to understand your perspective. What do you see? What mistake we did it to lost to that?
And again, this may be my own bias here, right? But I think people have to rely on authority because they generally, not always, but often don't have the toolkit to understand it themselves. I mean, I'm an expert in epidemiology, and in that little narrow slice of the world, yes, I have the tool. I can understand it, right? But the whole rest of the world, I don't have that training. I have to rely on other people. And I think that who the authority is and who's trusted has changed a lot over the last several decades. It used to be that everyone in the community got the same newspaper, and the news channels had basically the same story. You just chose the anchor man you preferred. And now it's so different.
You can get your news from
anywhere. And when people lack the toolkit to really decide for themselves, which it's not really reasonable to expect that they would have that, I think you end up with this really fragmented kind of, everyone has their own person that they turn to. And I don't know if that's our fault necessarily. I do think that, in COVID, there were lots of lessons learned, right? But I think it's true kind of broadly.
But I was just saying that maybe this is our fault because as a scientist, sometimes we don't know how to communicate. That is always, just how we can prepare that communication tool, because communication is different level, and also science is constantly changing. Right now, you are saying that this, chemical is not good, but in maybe 5 years later, you will say that it was not the problem. There is some other component in that chemical was the problem. Just science is changing, but when message is not, connect or how you communicate it, sometimes that creates that not trusting the results because we are changing constantly.
Yeah, I think, there's a lot there. I do think that, one, sometimes people just publish their paper, and that's just one data point, right? And then sometimes we get 24 people together in France for a week, and we summarize the literature, and we say, this is what we know. Those are very, very different. But I don't know that they get handled that differently in terms of our communication, right? We make a lot, it's press releases and interviews and this about this study, but now here's someone who's summarized 50 studies, and it's a consensus
author came
from
together.
different disciplines, and like we actually feel like we know something. I feel like we need to spend more time on those kinds of things. I mean, I think the other thing that happens, and I'm not really into blaming people here, but the media and reporters, as stories change, and also as scientific experts who contribute to that, as science evolves, we have to be committed to continuing to tell that story and inform people. And it's two ways, right? It's from the reporter, but it's also from the experts. I mean, if you just come in at one point in time and you say, make your sentence or whatever for the article, and then that's all there is to it, then how should we expect the public to keep up with it? But I do think it's tough.
No, thank you. And I want to go back to your research and also your background a little bit more, and because you talk about the air pollution, and also I know that you are working with the wildfire, which is very big problem in our region. So just tell me about your research a little bit.
Yeah. So I tend to work on sort of large population studies. So when I say that I'm studying the health effects of outdoor air pollution, we're looking at things like kids' urgent care and emergency department visits for asthma, or low birth weight or something like that across the whole population. I'm not going out personally and putting monitors on individual people, like backpacks, and seeing what they're. I mean, people do that, and that's interesting work. But I tend to work at much sort of larger population scales. So we have a study in Reno where we're looking at wildfire smoke and cardiovascular and respiratory health effects of that, and also blood pressure. We have a study that is across 10 different cities in the western United States that have problems with inversions in the winter. So when you have temperature inversions in the winter, the pollution kind of stays near the surface. It doesn't mix up into the atmosphere. And that's typical of cities like Reno that are in basins surrounded by mountains. So we work in Salt Lake City and different places like that are similar geographically. We've done some studies on dust. Because with climate change, dust concentrations have gone up, and that's going to be a bigger problem, particularly in the Southwest. So just a variety of sort of larger city level or multi-city level kinds of studies.
But when you do this kind of studies, what kind of team you are working? Because again, everything is more interdisciplinary and everything.
Yeah, so I do not try to do my own air quality modeling. I always work with at least one person who's an expert in air quality, either modeling or measurement, or just depends on what we need. Often they come from like chemical engineering or environmental engineering, because those people tend to do a lot of modeling. And those are the people who, in my experience, I've found are most interested in like human exposure and not just like atmospheric chemistry for the sake of interesting chemistry. And so I've worked with a couple different people. Some of them use satellite remote sensing images to, look down from above and understand what pollution levels are like. Others use very sophisticated models that involve chemistry and emissions, and you kind of press the button and it goes forward and all mixes together and we see what comes out of it. And then, of course, there's the regulatory monitor networks that EPA maintains that we use for sort of ground truth, like really high quality measures. Yeah. And then, we work with statisticians, we work with clinicians who are experts in the health outcomes we're studying. But really, it's that link with people who really can do the exposure science and the outdoor air quality modeling that is my most important collaborator.
But it's clinical perspective there too. Because you are taking the hospital data and just looking to, again, emergency admission and other pieces. So again, I'm trying to give that perspective that when you are really creating a scientific product, this is a lot of people that are working in the behind the scenes. It's not just.
Oh, absolutely. And we've learned lots of lessons about screwing up how we code things, or like assuming that all clinicians are coding things the same way, and then you start to look at different hospitals, and you see very, very, those are all things we have to look at and try to deal with when they happen.
When you do this kind of studies, what is the biggest challenge actually?
I think the biggest challenge is obtaining data and then getting data ready to analyze. Once everything is nice and neat in a data set, it doesn't take today's computers that long to actually do the analysis. One of the challenges we face, apart from somewhat mundane things like, cleaning and coding and things like that, is a lot of times the magnitude of the health effects we're looking at are fairly small. So, we have a wildfire smoke or, bad pollution, and it might increase your risk of a heart attack by 1%. And that sounds very small. And then people ask like, well, what does that mean for me? And then I say, well, or maybe it's 0.5%. But it's like, should you not go outside and play golf or something because you're worried about a 0.5% increase on a risk that's already pretty low? And so we're in the business of trying to tell the difference between a tiny increase and no increase. But it's also important to remember, in terms of the significance of what we do, that all of us breathe air, and there's 340 million people in the United States. And so even if you have a very small increase in risk, which is hard to know what to do with from an individual standpoint, from a public health standpoint, when everybody's breathing air, those tiny little increases in risk are meaningful. They add up day after day after day after day.
That is the part. And can you talk about a little bit Reno and air pollution? Where are we right now?
Yeah, Reno. So this is like it's probably some people have seen the American Lung Association State of the Air, and we get an F. And these sort of news articles about how our pollution is worse than Los Angeles and things like that. And like there is a component of truth to it. Our worst days are worse than Los Angeles's worst days. They really are. We can have just horrible air pollution here, but our typical day is beautiful. If you live here, it's gorgeous, right? And so I always find it a little bit disingenuous. Like yes, we have problems. We have some days that are bad, and sometimes, some years when it's really bad, we can have a whole month that's really bad, and that's concerning. I'm not trying to trivialize that, but that's difficult for our air quality regulators. A fire that occurs 200 miles away is different for Washoe County to really manage. The pollution that we're getting from tailpipes and smokestacks and things like that in Reno is very low, relatively speaking, and much lower than like Los Angeles. So. But
what do you think about as a wildfire happens? So as a community, what we need to really do? What is the prevention?
Yeah, it's an interesting question. So there's obviously fuels management, trying to prevent buildup of fuels so that when fires happen, because fires will happen. Fires are part of natural ecosystems, like that they are not mega fires. So I think that fuels management is probably the biggest thing we can do. Obviously, there's the sort of preparing your house so that it doesn't catch on fire. If you're at the sort of wildland urban interface where you're with lots of Jeffrey pine trees around you, clean up around the house so that the house doesn't catch on fire. But if you're more like, not inner city Reno, but like in the urban core of Reno, your house is very unlikely to burn from the fire. But yeah, another thing I tell people are indoor air purifiers. So they're like maybe $150 or $200, and you can carry them around with you, and you set them down next to it. If you're working in your bedroom, you set it there next to you. If you're cooking in the kitchen, you bring it in the kitchen, because it's not big enough to do the whole house. But they really do work, and they can really decrease your exposures during those high air pollution events.
And also there is a vulnerable population in that one, like kids, just the elderlies, just if you have a chronic diseases, you need to be more careful about what kind of prevention you need.
Absolutely. I always suggest that people kind of trust their bodies to some extent. should I go for a walk today? Well, if you go for a walk, how do you feel? Do you feel fine? I mean, it's not to say that there aren't risks of that. I mean, there's long-term cancer risks and things like that of air pollution, but we're stuck. We have to breathe air, and if you go for a walk and afterwards you're wheezing and feeling really bad, well, the next time the pollution's that level, you should maybe not do that. So it's hard to sort of prescribe something that fits everybody, because as you said, there's vulnerable populations, everybody's different.
But is it bottom line, just if you can summarize, why should people care about your work, really?
I mean, I think...
Specifically for your work.
Yeah. No. Well, it's a fair question, right? I think that at a couple levels, one, even if you are fortunate and a very healthy, robust person, I think there's value to clean air. We live in a beautiful part of the country. I like to look out my window and not just see the city, but see the mountains behind the city, and I think there's value in that. And then, of course, there's value from the health standpoint, too. I mean, going outside and exercising or going for a walk and breathing clean air, it's healthier for you, it's more enjoyable, and it's, I don't know, I just think there's a lot of benefits to it. And then there's the whole climate change that we haven't really talked about, too, but many of the pollutants that we're worried about are also greenhouse gases, and climate change also has consequences, right? I mean, more wildfires, bigger wildfires, more hurricanes, stronger hurricanes. I mean, there's like flooding. I mean, there's a lot of things that impact health that way too. And maybe, we're not as worried about some of those issues here. We're worried about the fires a lot. We're not worried about hurricanes in Reno. But other people have other things. Coast, exactly.
The whole life is the hurricane.
Exactly.
The hurricane. So you're right. Just makes sense. So we're almost coming to our last part of our talk, and my last question really to you: what gives you hope for public health?
Well, I mean,
we should have a hope.
Yeah, I think that I always think that there's sort of like a long-term trend, and then there's blips in the trend, so to speak, right? I think if you look in my area of research in air pollution, when EPA was founded in the 70s, I mean, we were worried about breathing lead, right? Because there was, I mean, it's the quality of the air now, despite the sort of the setbacks that are happening due to wildfires, is so much better than it was. And yes, we run into challenges, and maybe we aren't going to change standards in the next few years or something like that. But I think the long-term trend is there, and I think that trend is present in a lot of different areas too. So I think you have to kind of focus on the long game. Yeah, you have to keep doing. You can't just sort of say to yourself, well, no one cares about my air pollution research right now, so I'm going to stop. Because 5 years from now, we might be in a different setting where we are ready to look at the literature and maybe seriously consider doing changes. And if you're not working now, you won't have the information that's needed down there.
It's true. As a public health, we should continue our work.
Absolutely.
We cannot give up. This is not that kind of thing. But thank you so much.
Yeah, thank you. This was fun.
It was really nice to have you in my kitchen.
My first Turkish coffee.
You enjoyed the coffee too.
Yeah, that's
great.
great.
Thank you so much again.
You're welcome. I'm glad to be here.